Good afternoon, everyone. Thank you for joining us. Today, we're joined by Jonathan, and he'll be going over understanding your options, primary care designation strategies. We're a smaller group today, so please feel free, unmute and share your question, put it in the chat. I'll be watching the chat. If you're watching the recording of this, if you have any questions at all, please feel free to reach out to myself or Jonathan. With that said, Jonathan, I'll turn it over to you.
Thanks, Laura. Now, I know many of us have talked about this in the past, and when we talk about our designation strategies, it's important that we should really be focusing on these things on an annual basis. When we talk about the alignment and designation of practices, it's not a one-size-fits-all, and it's definitely not a one-and-done type strategy. As our cost structure changes, as the industry continues to change, we have to continue to evaluate different opportunities as a means to ensure that we continue to operate financially in a solvent position, but also to ensure that we can continue to serve as that vital safety net provider going forward. Only then can we ensure that we can continue to provide those services. Now, there are several designations out there. And again, all of those different designations have different requirements to operate in that designation. They also have different strategies. They also have different reimbursement methodology or additional revenue streams. We have to take all these things into account when we're looking at additional opportunities as a means to drive financial performance going forward. So I just want to emphasize again that especially in today's environment, as all of us have continued to see substantive and material cost increases or service disruptions or providers have left, we've all seen staffing shortages. We have to continue to evaluate all of these different options and opportunities as a means to drive performance going forward. So what are we going to talk about today? What we're really going to talk about is the rural landscape. Now, again, focusing predominantly on our rural providers, whether you're a critical access hospital, sole community hospital, or some type of provider that's operating within a rural landscape, we have to have a comprehensive understanding of what is the rural landscape today. In addition to that, we also are going to talk about the different requirements to establish one of these clinics. Now, just because we want to operate a rural health clinic or operate an FQHC, we still have to operate within that environment, and many of them have certain location requirements, or we have to ensure we serve a certain patient population to operate under that designation type. Then what we're going to talk about is the different practice designations themselves. Again, what are the different designations? What are some of the advantages, disadvantages? What are some of the nuances of those practices? And then what we're going to end on is really some reimbursement trends and strategic opportunities. In this section, what we're going to talk about is how the different designation types can impact the reimbursements you receive as an organization. And again, I've seen these impact hundreds of thousands of dollars or millions of dollars, depending upon how many clinics and the size of the clinics and the additional revenue opportunities such as 340B, that it is a material impact on the financial performance. We have to start to evaluate these opportunities going forward to continue to drive that performance and our improvement efforts. So what is the rural landscape? Now, when we look at the rural landscape and the rural environment, oftentimes the rural market accepts or addresses or is impacted by several barriers that we have to encounter on a day-to-day basis. Now, when we look at the landscape, often it is highly segmented and there's not as much integration as we see in many of our urban counterparts. And the reason for that is because oftentimes we maybe don't have the same number of providers or the same types of providers, or we don't have an integrated relationship with other care providers within our community, and we're not able to sustain the duplication of services across two different provider types. Again, all of these different things are preventing us or providing different barriers within that environment that is making it difficult for us to operate within that area. In addition to that, oftentimes in rural communities, there are additional things such as you have a provider that's operated in that community for 40 years and they want to remain staunchly independent and not become a part of your hospital or system or thing to that degree. Also, we have to take into account all the different regulations and requirements for operating within a different rural market. Now, when we talk about the opportunity and really around a primary care setting, around the different designations, because we operate within a rural community, there are several different opportunities around how to leverage those different designations and reimbursement opportunities as a way to improve the financial position of our organization. These things can come in the way of rate increases, whether it's increases to the fee schedule or alternative reimbursement methodologies. We can pursue programs such as the 340B if the hospital we operate under is eligible, or if we're in an FQHC. Again, all of these different things are ways that we can leverage those rural opportunities as a way to drive performance. Now, when we talk about rural communities, it's also important to emphasize that rural communities oftentimes have something going for them that is not seen in those urban counterparts. And what that is the relationships that we've generally built with our patient population and how we can actually continue to provide those services going forward. Now, even though we may not have access to the same services, we are still able to serve as a vital and viable safety net provider for our rural communities. Now, one thing I will emphasize though is as we are evaluating the services that we can provide within our community, we have to realize that we cannot be a one size fits all provider for our community. We have to start to evaluate the services that we can provide and whether or not we can sustain those services going forward. Just because we have an orthopedic surgeon that maybe wants to move to our community or a cardiologist or some other provider does not mean that our practice or our hospital can sustain that service going forward. We have to truly start to evaluate those services. Now, a couple of weeks ago, I think I presented on different strategies as to how to drive operational performance. And one thing I wanted to mention with regard to that for our provider practices, particularly when we're evaluating different strategies, is that we have to start taking a proactive role of evaluating the providers that operate within our community. And that's not only the providers that we directly employ or directly have contracted relationships with. If we want to expand services or start to evaluate the strategies around primary care and our different designations, we have to evaluate all of the providers that are within our service area. This will impact programs such as the RHC or FQHC or different things to that degree. Again, as we start to look at those services, if we have a provider that's providing primary care services and we want to look at adding OB-GYN services into that practice, if there's already another practice in our community that has 90% of the volumes, is there a chance that we can add OB-GYN services and still become viable from a financial position with providing those services? Now, again, it's not to say we don't want to provide those services. We just have to evaluate whether adding those services can position ourselves effectively as we continue to go forward. Now, what I'm going to talk about for a moment is the Medicare Economic Index. Now, the Medicare Economic Index is something that has popped up more prevalently in recent years because of the impact it has on the rural health clinic designation. Now, if we look over the past 10-year period and we look at that Medicare Economic Index, we can see it's been as low as a 0.8% and as high this year as a 3.8%. Now, when we talk about the average increase to that Medicare Economic Index over that 10-year period, it's been an average increase of about 1.6%. Now, if I were to ask everybody on this webinar today, how many of you are experiencing cost increases that is limited only to 1.6%, or even the 3.8% increase that we saw this year? And the fact is that most of us are seeing cost increases that is far beyond what that 2.1% or 3.8% or the average of the 1.6% increase is. And what we have to start looking at is we have to start looking at operational components as a means to drive performance improvement. Now, as we look at those different operational components and the services that we're providing, designations and alignment is one of the strategies that we can evaluate as we start to look at those components going forward. Now, when we talk about these different parameters and these different programs, all of this rolls up into the broader performance improvement model. Again, when we talk about performance improvement, it's the continual evaluation of the services that we're providing, the financial benefit of providing those services, and the ability to sustain those services going forward. Now, everything ultimately rolls back to the value to the community. Now, when we talk about rolling everything back to the value of the community, we have to ensure that the designation and the overall strategy that we take fits within the framework and the broader strategy for that organization as a whole. Again, if we're an independent rural health clinic, or we're a hospital-based rural health clinic, or we're a provider-based clinic, or whatever the case may be, we have to evaluate the impact of the designation on the broader strategy and the ability to continue to provide those services going forward. The strategy around the designation and alignment is only one of the components that goes into the broader framework of that entity as a whole. Again, it's equally as important as the quality of care we're providing, the cost structure, the financial services, the providers we have, all of those different things. The designation and alignment of that practice can have and will have a material impact on the financial solvency of that organization going forward. Now, when we talk about performance improvement and we talk about the different areas, as we start to look at the different designation types and the different things that we want to evaluate for those practices, we really have to start to evaluate from the framework of driving and improving performance improvement as a whole. Now, what we really have to start looking at is breaking down the barriers between quality and finance and coming together as a collective unit. Now you're asking yourself probably, why am I bringing this up on a designation or an alignment presentation on different options around strategies for our practices? And the reason for that is our cost structure and the delivery of services has a direct impact on the reimbursements that we receive and our cost structure as a whole. Now, because our cost structure on some of these designation types will directly impact the reimbursements that we receive, we have to start to evaluate different operational opportunities as a way to reduce down that cost per unit of service and drive down that cost structure so that as we evaluate the different designation types, we can continue to improve ourselves financially and do not put ourselves in a bad position. So again, evaluate the operational components, break down the barriers between quality and finance, and start to realize that how we are operating in today's environment may not be the best from a future environment as we continue to expand services going forward. Now, many of the designations have different requirements around the different shortage areas. Now, when we talk about the different shortage areas, it's important to note that these shortage areas have a direct impact on the services that we provide under those different designations. Now, different shortage area requirements, the first one is really around your rural area location. Now, when we talk about a rural area location, this is predominantly used for our rural health clinics. Now, recently there was a change at the federal level that is impacting the ability of rural health clinics to start becoming, or practices to actually become rural health clinics. Now, prior to the 2020 census, there used to be a term called an urbanized area established by the Census Bureau. And the way it was established at that federal level is so long as the location that you are looking to establish a rural health clinic was not in an urbanized area, you were considered rural for the purposes of the RHC program. Unfortunately, as a part of the 2020 census, the Census Bureau decided to get rid of the term urbanized area. Now, because they've gotten rid of the term urbanized area, the federal law itself actually draws attention to the term urbanized area. CMS right now is working through how they want to apply the parameters for the rural versus urban. Now, as a part of that Census Bureau, the Census Bureau also ended up changing the definition threshold for urban and increased it from 2,500 to 5,000. Now, the problem is that even though they increased it from 2,500 to 5,000, under the prior definition, an urbanized area was an area of 50,000 people or more in a single census tract or a collective of census tracts or another grouping that the Census Bureau ended up deciding. Now, because they've gotten rid of that urbanized area, the urban area has dropped to that 5,000 threshold. So if you are evaluating a rural health clinic going forward, ensure that you evaluate the ability to meet the requirements and ensure that you reach out to either Laura or somebody else to ensure that location actually qualifies as rural for that purpose. Now, when we talk about some of the shortage areas, there's different types of shortage areas. Now, because predominantly what we're talking about today is primary care and those services, when we talk about the different things, we're going to be talking about primary care shortage areas. Now, from a health professional shortage area, there's three main shortage area types. You have your geographic HPSA, a population HPSA, and a facility HPSA. Now, a geographic HPSA looks at the number of providers relative to a geographic area. So let's say you're looking at Tulsa or Duncan or somewhere else across the state of Oklahoma. What they would look at is they would look at the number of providers within that geographic area relative to that patient population. And if the number of providers was not high enough relative to the patient population, then you could qualify for a geographic health professional shortage area. Now, when we talk about the different programs, there's different criteria for what number HPSA score you need depending upon what type of benefit you're going for. Now, for the purposes of the Rural Health Clinic program, it doesn't matter if your HPSA score is a 1 or a 15. So long as you have a HPSA score that's a shortage area, you can qualify for that Rural Health Clinic program. Now, there's other programs too that if you operate in a health professional shortage area, you can get a 10% increase on the fee schedule for providing services, or you can qualify for your J1 visas or different things to that degree. So again, all of those different things have different requirements relative to the scores of those numbers. But for the designation itself for a practice, a rural health clinic only needs to be a score of a 1 or greater. The next is a population HPSA. Now, your population HPSA looks at a specific group of people, such as low income or Medicaid or certain things to that degree, relative to the patient or the providers in that population. Now, again, same thing for the geographic. It does not matter if your score is a 1 or a 10. So long as you have a HPSA, you can pursue that RHC program. The last is your facility HPSAs. Now, a facility HPSA is given to a specific facility itself to designate a shortage area for that facility. Now, oftentimes these are given out to facilities to qualify or grandfather that facility location in relative to that population or to that shortage requirement. Now, depending upon this, you cannot use a facility HPSA to go in for an alternative or another location or designation. It ties to that practice that is established itself. So again, we cannot use a facility HPSA, for instance, to go in for an RHC program. The next is our medically underserved areas and our medically underserved populations. Now, a medically underserved area can be used for an FQHC or an RHC. And what this looks at is, again, similar to your HPSA, it looks at the number of providers and different services within a geographic area. Now, depending upon that medically underserved area will ultimately dictate whether or not you can go for a certain designation. Now, one thing I want to emphasize, the differentiation between, say, an FQHC and an RHC is if you want to look at pursuing a rural health clinic designation, that shortage area designation has to be current within the past 4 years. If you are pursuing the FQHC program, so long as it was at some point designated as a shortage area, then you can pursue that medically underserved area and use that as a way to go for an FQHC designation. Now, the medically underserved population is similar to the population-based HPSA. It looks at a number of patients within a certain underserved area relative to the population and the providers itself. Now, one thing I want to emphasize also is a differentiation between the FQHC designation and the RHC designation is the RHC designation cares where the clinic itself is located. So the clinic itself has to be located in a rural shortage area. An FQHC does not necessarily care where the clinic is located, it cares the people that the clinic is serving. So the clinic itself in that setting has to ensure that they provide services as an FQHC to patients from a medically underserved area or from a medically underserved population. A rural health clinic does not necessarily care where the patients are from. The clinic itself has to be located in a medically underserved area or a health professional shortage area. So that's one of the key differentiations between those different designation types. Now, the last of the designation types is your governor designated secretary certified shortage area. Now, this is where a state can go out and designate a certain type of region as a shortage area. And again, if your location qualifies as a MUA or a HPSA, then those would generally not qualify for the governor designated secretary certified shortage area. This is a way that a state can group together a different subset of regions as a way to qualify a medically or a governor designated shortage area. Now, oftentimes we will see these where they are established for an entire county, where they're looking at an entire county as a shortage area, and they'll designate the entire county relative to the services provided within that county. But nonetheless, this is another way for the Rural Health Clinic program that we can actually pursue that designation going forward. But again, they do have to be valid within the past 4 years. Now, what are the different designation types? The first one we're going to talk about is the Federally Qualified Health Center. Now, the Federally Qualified Health Center, they're established across the country. And as I mentioned a few moments ago, these practices have to identify a specific patient population that they want to serve as a part of the FQHC designation. Now, many of us realize that as operating as an FQHC, it does come with certain financial advantages. They get an enhanced rate, they get the ability to participate in the 340B program, they have malpractice insurance savings. However, there are certain governance requirements established as a part of that FQHC that oftentimes make it difficult to continue to operate as an FQHC. In addition, there are significant administrative burden operating as an FQHC. Now, the ability to access the 330 grant and the ability to go after that additional funding offsets much of the cost or some of the cost associated with operating as an FQHC. But nonetheless, there are certain core services you have to provide as an FQHC, or you have to have contracts that you're providing those services or that somebody else is providing those services through a contracted relationship. Now, one thing I want to emphasize as a part of the FQHC is the governance requirements associated with the FQHC state that that entity cannot be owned and operated by another nonprofit hospital. The governance of that FQHC has to be members that are members or patients at the clinic, that FQHC itself. Now, there is an exclusion to this governance requirement stating that if you are a governmentally owned entity, whether you are a district owned hospital or a county owned hospital, those type of entities can own and operate an FQHC under the umbrella of that entity, but no more than 10% of the 330 grant funding could go to government owned FQHCs. Again, the purpose of the FQHC is to provide services to a disparate population. The overwhelming majority of those are not for profit entities where the governance is actually controlled by patients being services at that FQHC. When we talk about the services that they have to provide, again, they have to provide the primary care services, dental services, other type of services. If they can't provide services directly, they have to have a formal written agreement for the services that are being provided. They also have to ensure that, as I mentioned earlier, that they provide services to patients that are from a medically underserved area or from a medically underserved population. Now, the next designation we're going to talk about is our provider-based clinics. Now, our provider-based clinics are clinics that are owned and operated as a department of a hospital that is the main provider of that clinic. Now, when we talk about our provider-based clinics, these are predominantly operated as departments of the hospital, and they generally qualify for a technical charge and that facility charge and the ability to bill for a professional charge. Now, there's been several changes that have come out relative to provider-based clinics, particularly for our PPS-based hospitals, those under the OPPS and IPPS reimbursement methodologies. And what changed as a part of those is what's called site-neutral payment policy. Now, prior to the passing of that site-neutral payment policy perspective, provider-based clinics that were owned and operated by hospitals that were not a critical access hospital used to receive a full OPPS APC payment for providing services to off-campus locations for patients. And that APC payment, let's just say it was about $100. In addition to that, they also used to receive a professional fee service for the provider actually doing the services themselves. Now, as a part of that site-neutral payment policy, CMS came out and said, we are no longer going to provide a full APC payment to this practice or to this hospital just because it's owned and operated by a hospital. And going forward, all off-campus practices, and the way Medicare defines off-campus is any location that is greater than 250 yards from the entity that owns it, or that main provider, that main building that owns and operates that practice. So what Medicare said is going forward, any off-campus practice is no longer going to get that full APC payment. Going forward, they're going to get the same site-neutral payment policy, whereas the rate that they receive for the technical and the professional equals what a professional fee would be for a non-provider-based clinic. Now, on campus, those that are within 250 yards of those hospitals or that campus still receive that APC payment in addition to that pro fee payment. Now, this change in this methodology is what caused a ballooning or a substantial increase in the number of rural health clinics that were owned and operated by hospital entities across the country, particularly for those that were non critical access hospitals. Again, because of the inability to get that full APC payment anymore. Now, if you are a provider based clinic owned and operated by a critical access hospital, you receive an uncapped cost based rate for the facility component, and you are able to bill for the professional component. Now, in addition to that, our critical access hospitals can elect what is called Method 2. Now, by electing Method 2, that is where you elect to consolidate your claim and submit a single claim that has both the professional and the technical component on a single claim. And by doing that, Medicare will give you an additional reimbursement on the pro fee side by electing to consolidate those claims. So, this is an opportunity or something we should be looking at if we are operating a provider based clinic under a critical access hospital. Now, Method 2 is not only applicable to our provider based clinics under a critical access hospital, we can also do this for the emergency department. We can also do this for diagnostic imaging. We can do it for those outpatient services where we are billing for a professional and a technical component. The next designation is our rural health clinic. Now, our rural health clinic has seen some changes in recent years. It's predominantly tied to the reimbursement methodology. But nonetheless, when we look at our rural health clinics, this is a change in a methodology where we receive an all inclusive rate for the services that we provide. Now, one of the benefits or significant benefits for the rural health clinic program is the reimbursement rate that we receive for an APP, that being a PA or an NP, is the exact same as the reimbursement that we receive for a physician. So if we bill under a provider-based clinic or a freestanding clinic and we have a physician and an APP, under that methodology, an APP gets 85% of the fee schedule in that situation. Under a rural health clinic, they receive the exact same reimbursement to that degree. In addition to that, under that rural health clinic, a unique thing about this program is you get the same reimbursement rate for Medicare and Medicaid across all of the services that you provide as a qualifying visit. And what I mean by that is if you bill a 99212 or a 99215, from the Medicare approach, you get the exact same reimbursement for both of those services. You do not get a higher rate for the 99215 versus the 99212. Now, there are certain services that we have to provide as a rural health clinic, and there are certain requirements. Again, we have to employ an APP, we have to provide certain lab services, we have to be open and publish our hours of operation. All of those different components we have to evaluate when we're determining the designation and if we want to be a rural health clinic. Now, one thing I want to emphasize also is that is a unique thing with our rural health clinics. There are two main things or major things where rural health clinics are exempt from other laws that are in place and other administrative rules relative to those programs. Now, the first one ties to the provider-based rules, which is 42 CFR 413.65. Now, in those administrative rules and in those rules, a clinic has to be located under those provider based rules within 35 miles of the hospital that owns and operates that location, unless you are a rural health clinic. So, according to the provider based rules, you can actually open a rural health clinic and establish it as provider based and operate it anywhere within the state of Oklahoma. And in fact, you can open it any state contiguous to the state of Oklahoma so long as you meet the laws of both states. The other way that the rural health clinic meets or is exempt from a requirement under 413.65 is the public awareness requirement. Now, under the public awareness requirements, if you operate as a provider-based location, you have to share the same naming convention as the entity that owns and operates that clinic, unless you are a rural health clinic. So a rural health clinic does not have to say it's owned and operated as a department of X hospital on the signage on the exterior of the building. Now, granted, when the patient comes into the clinic, you have to state and make the patient aware that they are a part of X hospital. But on the exterior of the building, you can keep whatever naming convention you want for establishing that clinic. Now, the other part of the requirements that's applicable to the critical access hospitals is a rural health clinic is exempt from the distance requirements for a critical access hospital. And those distance requirements are the CA distance requirements that says that any provider-based location under a critical access hospital has to be 15 miles on secondary roads or 35 miles on primary roads from the next closest facility that owns and operates. So with that rural health clinic, you can actually establish a rural health clinic. So long as it's a rural health clinic first, you can actually establish a rural health clinic on the campus of another hospital and operate it under that critical access hospital, so long as it meets that rural shortage area requirement. Now, the caveat to this that I want to say is it has to be a rural health clinic first. Do not open a location on the campus of another facility or across the street or within the distance requirements, that 15, 35 miles from that next closest facility, as a provider based clinic while you're waiting for your RHC designation. It has to be an RHC first. That's the only way you can get around that requirement. One thing I also want to emphasize too is there was a recent change to the critical access hospital distance requirements. Now, recently, CMS has come out and changed what counts as a primary road for the distance requirements. Now, if you went back a year ago, a primary road was any road that was a US highway or interstate, any state road that was two or more lanes in either direction, or any road that was listed on the National Highway System road system. CMS has come out and changed so that now, if a state highway does not have two lanes in both directions, it is now considered a secondary road, the same as a state road. So US interstates and highways, similar to state highways, now have to have two or more lanes in both directions to count as a primary road. If not, it is now considered a secondary road. The reason why I'm emphasizing this is because for you operating as critical access hospitals, this could impact the type of designation you establish, because US interstate highways and those roads may not count as a primary road anymore. The next thing I want to emphasize real quick before moving on to the last designation is the change in the RHC reimbursement methodology. I'll move through this pretty quickly. Now, as a part of the Consolidated Appropriations Act of 2021, there was a fundamental change in the RHC reimbursement methodology. Now, for our independent clinics, the only thing that changed for our independent clinics was a change in the upper payment limit itself. The methodology remained the same. And back in 2021, it went from about $87 up to $100. This year, it's $126 as an upper payment limit. But the methodology is exactly the same. For our RHCs owned and operated by hospitals with 50 or greater beds, again, methodology is exactly the same. The only thing that has changed is the methodology going to an upper payment limit this year of $126. And again, that's trending to $190 in 2028. What has really changed is the methodology for our provider-based rural health clinics owned and operated by hospitals with fewer than 50 beds. And this differentiates between grandfathered and non-grandfathered practices. Now, if you are not a grandfathered RHC, meaning that you are not owned and operated and established by 12/31/2020, or had applied to become an RHC by that date, you are now subject to the same upper payment limit as the independents and the greater than 50 beds. This is truly a change in the methodology. You no longer get an uncapped cost-based rate. You no longer can establish a cost-based rate that is trended forward. Even if you are a grandfathered RHC, meaning that you were established by 12/31/20 or enrolled to become by 12/31/20, you are now subject to an all-inclusive payment upper payment limit that is based on your 2020 reconciled cost report rate that is then trended forward based on the Medicare Economic Index. So again, gone is a full uncapped rate. We are now subject to an upper payment limit. What is the last designation? And this is our freestanding health clinics. Now, as I generally would talk about clinics, our FSHCs are generally the worst of the worst. If we can usually be any other designation type, we generally want to try to be that other designation type. Our FSHCs are only eligible for fee-for-service revenue. They are not able to participate in 340B. The benefit of generally being a freestanding health clinic is if we cannot qualify for one of those other designation types, this allows us to own and operate a clinic, but will not allow us to yield any of those additional opportunities. So it can help us from an alignment and an integration of providers. It will not help us on a reimbursement approach by being able to pursue one of those alternatives. Now, what are the reimbursement trends and strategies? Now, as we talked about the different reimbursement designation types, we mentioned our FQHCs, our PBCs, our PBRHCs, and our FSHCs. Now, as we talk about those different revenue opportunities and reimbursement options, we can see that each of those have different green and red boxes. Now, as I mentioned a moment ago, generally the only one we don't want to be is the FSHC. If we can be anything else besides that freestanding clinic, we want to be that other designation type. Now, depending upon your cost structure, the services that you're providing, and so forth, will ultimately dictate what is the most advantageous designation among the final three. Now, if you're a critical access hospital and you're looking at establishing a practice, again, if you're not districtly owned or governmentally owned, that wipes out the FQHC. So, really, we're looking at our provider based clinics and our provider based rural health clinics. As we evaluate these different designation types, we have to look at the cost structure, the services, the provider types, looking at whether or not it's APPs or physicians, and all of those different things to determine which one is the most advantageous type. Now, prior to the Consolidated Appropriations Act of 2021, I would say 80 to 90% of the time, if you were operating in a rural market owned and operated by a critical access hospital, the most advantageous designation type was most likely a provider based rural health clinic due to the cost structure. However, in today's times, and it doesn't matter whether you're a critical access or whether you're a PPS hospital or so forth, I would say in today's times, it's 50-50 whether or not it's better to be a provider based clinic or a provider based rural health clinic. We have to look at our cost structure and we have to factor in how that plays into the reimbursement methodology and all of those different factors. Now, what are the reimbursement strategies around these different designation types? And it really comes down to four main strategies, what we have to look at when we're evaluating the optimal designation. The first strategy is around converting eligible practices to a designation that yields the most advantageous reimbursement opportunity. Again, maybe we're an FSHC and we want to be a rural health clinic that can qualify for 340B. We want to look at all of those additional opportunities going forward. The next is for us that are in a system relationship. If we're in a system relationship, we want to look at the realignment of practices across the system in a way that yields the highest return. Maybe we're operating a physician group that's a wholly owned physician group as a bunch of freestanding clinics. Maybe we want to look at converting those to rural health clinics or provider based clinics so we can leverage 340B. Again, we have to realize there is no one size fits all approach. What we can also look at too is the realization that under these different designation types, many of the requirements to pursue, say, 340B or so forth, is the hospital has to own and operate the clinic. They do not have to employ all of the staff and the providers. So there are different ways that we can create professional service agreements and so forth as a way to leverage the program. The next is looking at the integration of specialty practices and providers when possible into a rural health clinic or provider based clinic as a means to drive reimbursement. So, again, looking at these as opportunities to that degree. And then the last strategy is looking at the acquisition of practices, whether it's an independent practice, whether it's a system based practice, or whatever the case may be, to look at acquiring those practices within our entity as a means to leverage one of these alternative designations. Now, the next four slides, I'm going to walk through the financial impact of each of these designations on a different practice to really show how it ended up impacting these organizations going forward. Now, the first one that we ended up looking at was what was the impact to an organization going forward? And what we wanted to look at was relative to strategy number one. Now, this was a provider based clinic that was owned and operated by a hospital. And they had about 29,000, 28,000 visits with about $4.2 million in reimbursement. Now, because they were operated under a hospital that did not qualify for 340B, there was no benefit for the 340B program. But they were receiving about $149 prior to the site neutral payment policy approach. Now, what I want to emphasize too is this was multiple practices. They had some on campus and some off campus. But nonetheless, if they were to apply the site neutral payment policy perspective, their reimbursements would have dropped down to about $137. They would have lost out on about $345,000. Now, this hospital had greater than 50 beds. So what we had looked at was prior to the change in the RHC reimbursement methodology, what would have happened if we converted all of those practices to RHCs? Now, again, they would have gone from the $136 after site neutral to $86. Their reimbursements would have dropped by about $1.4 million by changing to a rural health clinic. Now, what's interesting though is this hospital also had an average daily census of about 20, so they could have easily dropped the number of beds to fewer than 50. Now, if they were able to drop the beds to fewer than 50 and establish them as RHCs prior to the change in that Consolidated Appropriations Act, they would have gained $1.4 million in reimbursements by changing the designation and dropping their beds. Now, to take this post 4/1/2021, if they did it in today's environment with the change in the reimbursement methodology, again, blending Medicaid and Medicare, they would have lost out on $253,000 in reimbursements. So what we can see is over a couple year period, the change in the methodologies, the change in the reimbursement methodologies applied to those designation types would have a material impact on the reimbursements received by this organization. Now, luckily, they were able to convert those practices and drop their bed before the change in the Consolidated Appropriations Act, so they were able to lock in that higher rate and establish that for the rural health clinic as a grandfathered rate going forward. So what we want to look at is an independent clinic. Now, again, this was a freestanding clinic that had about 8,500 Medicare and Medicaid visits. Now, what we looked at was we looked at the reimbursements in the current state. For Medicare and Medicaid, they received about $95 per visit, $800,000 in reimbursements. Now, if they were to change to a rural health clinic before the change in the law, their Medicare rate would have gone to $86.32. Granted, Medicaid would have gone up, but they really would have swapped the reimbursements between the two. It would have only been about a $7,000 increase in reimbursements if they converted to a rural health clinic. Now, if they were to convert after the change in the law, again, when we ended up looking at this clinic, the upper payment limit was $113. Their cost was in excess of $113. They would have picked up $129,000 increase in reimbursements if they were to convert to an RHC post the change in the law. So again, we have to evaluate the designations and how these things play out. The next area looked at the realignment of practices within a system to realize what the net impact on that system would have been. Now, this was a system that operated several clinics across the system that had about 53,000 visits and about $5.9 million in reimbursements. The average reimbursement was about $110. What we wanted to look at was the impact of reimbursements if we align them under a critical access hospital and a short-term acute care hospital. Now, when we look at the difference between the two, the short-term acute care hospital did not qualify for 340B, so this is a revenue impact to that organization. Putting them under the critical access hospital, they did qualify for 340B, but there's a dilutive impact on the reimbursements that you receive for other cost-based services at that hospital because you would be stepping down more costs to these RHCs. Now, looking at the impact, again, $4.2 million under the short-term acute care, $5.7 million under the critical access hospital. Now, this was before the change in the law. If this happened post-change in the Consolidated Appropriations Act, that benefit would have been capped at $113. The benefit would have dropped to $1.3 million versus the $5.7 million. One thing I want to emphasize also is the benefit is solely attributed to the ability to qualify for 340B under those critical access hospitals. Now, if they had trouble signing up or materializing the benefit for 340B, they could have actually been upside down by converting these clinics post the Consolidated Appropriations Act. Again, this is something that we have to look at and factor in as we're evaluating these practices. The next looks at integrating a freestanding clinic into a provider-based clinic under a critical access hospital. Now, this hospital operated a private physician practice and they also operated a provider-based rural health clinic. Now, by integrating that provider-based clinic with that freestanding clinic would have improved the net reimbursements by about $37,000. And the reason for that is because of the cost structure that would have been rolled into that clinic and the number of visits that they would have got into that RHC that would have increased the net financial position of that practice and of that combined entity. Now, again, because this clinic was grandfathered in, it would have been able to receive that full impact going forward. If they looked at doing this post-consolidated or in today's environment, both of those practices may have been subject to the upper payment limit. Again, we want to take these things into account. The last area is looking at the acquisition of a practice and establishing it under the critical access hospital as a provider based rural health clinic. Now, this was an independent practice that operated in the same community as a critical access hospital. And the two had worked together to figure out how to consolidate and merge those entities together. Now, this was a practice that had 2,700 visits. They were receiving about $257,000 from Medicare and Medicaid. Critical Access Hospital was receiving about $11.2 million in reimbursements for all of their services. Now, if they were to integrate this practice under that Critical Access Hospital prior to the change in the Consolidated Appropriations Act, this practice would have gone from an average reimbursement rate of about $94 up to $199 per visit. Granted, they would have also received $180,000 in 340B revenue. There would have been a minor negligible impact to the other cost-based reimbursements they received by stepping down costs to these rural health clinics, but nonetheless, the benefit would have been $261,000 for the combined entity to acquire this practice and roll it up under the Critical Access Hospital. If they were to do this post-Consolidated Appropriations Act, again, the average reimbursement would have gone from $94 to $113, a minor pickup, but they still would have had the same dilutive impact on their cost-based reimbursements. So they would have lost out on that $200,000 there. Now, granted, the combined entity would have still gained about $27,000 in reimbursements, but the sole benefit or the overwhelming benefit is the ability of getting the 340B. If they were to lose 340B, then all of a sudden they would have been worse off by acquiring and integrating that practice into that hospital. Now, when we talk about all these different strategies, I know I've gone over it at a high level. We have to start to evaluate and realize there is no one size fits all approach. We all have different strategies that we can employ as a means to start to drive performance going forward. And as we look at these different opportunities, we can continue to evaluate these opportunities as a way to ensure that we effectively align and designate these practices going forward. I'm going to pause now and see if there's any questions that I can answer or anything around the different practice designations or different ways that we can leverage these opportunities.
Hi, Jonathan. I'm not seeing anything in the chat at this time.
Okay.
Well, thank you, Jonathan, for the great presentation today. Just to kind of go back several slides, we get, as the Office of Rural Health, we get a lot of questions regarding distance, especially in relation to the rural health clinics, when our critical access hospitals are looking to either move a clinic or set up a new clinic. So thank you for going over that. And kind of as we move forward, this whole presentation, we've got a lot of questions about bits and pieces over the past year and a half. So this is going to be great to have available for folks. Thank you, everyone. Just one quick check to see if there are any questions. All right. Well, thank you for your time. Our next scheduled webinar is for April 20th. Once we get this one posted on YouTube, I'll be sure to share the link as well as Jonathan's slides. And everyone have a great rest of your day.